perineal resection with bilateral pelvic lymph node dissection. So in this operation, I use the blocking of robot from the between leg of the patient and use 2 arms over the right side and 1 arm over the left side. So first of all, we perform the lateral dissection down to the pelvic floor first. After posterior dissection, and then we will go for bilateral dissection. You can see this patient, because after neoadjuvant chemo irradiation, the pain is quite edematous. But with the robot, it can give us a stable platform and also a very fine view for the dissection. And lots of fibrosis and edematous. We will perform operation for the patient after neoadjuvant chemo irradiation 8 weeks after completion. And only one assistant is needed over the patient side to use the sucker to suck the smoke and also to provide some counter traction whenever necessary. So we finish our dissection down to the pelvic floor, and then we relieve the uterus which was previously up, and then we perform the bilateral pelvic lymph node dissection using the hot shear with the monopolar over the right side, the arm 1. And then arm 2 is the bipolar fenestrated progress. So you can see the external iliac artery and the external iliac vein. And then we dissect the fatty tissue and also the lymphatic. We key over the obturator foramen, then you can see the obturator nerve. And then after the left side, and then we proceed to the right side. This is the port ligament for the right side. And then you can see the iliac vessel and also the obturator nerve later. So actually, we are using selective approach to remove the enlarged pathological lymph node as shown on the restaging MRI. And this is the blood supply to the lymphatic lymph node from the internal iliac artery. So you can see there is a huge pathological lymph node. Actually, the patient has an eventful recovery, and post-op day 3, she was resumed on, was put on off the Foley catheter and then already ambulatory, and she was discharged home day 7 after the operation. The pathology come back to his G3 and not tumor, and 3 out of the 10 pelvic lymph node was positive for tumor metastasis. So indeed, over the past decade, the advantage of laparoscopic techniques has rekindled an interest in the concept of TME since it was first described in 1982, and has led to an increased practice of TME worldwide. Although minimally invasive TME is commonly performed nowadays, the laparoscopic pelvic lymph node dissection is not being widely practiced worldwide because it is technically demanding with a steep learning curve. But with the advance of the robot, so it can allow a stable platform with the very fine view and severe exposure with counter traction, so it can facilitate the fine dissection in confined space. Also, the superior dexterity of the endovis with 7 degrees of movement and thermal field range, it can allow accurate and precise dissection, resulting in preservation of the urogenital function. So I think actually robotic surgery is not really a new surgical approach, but only a step forward from laparoscopy in the evolution of MIS. And this system can overcome the numerous limitations associated with laparoscopy and offers significant advantage as how we have mentioned before. So actually the need to overcome the limitation of the existing surgical approach or the need to improve the result of current treatment options drives the constant evolution of medical technology. So with the continuous advance in the robotic instrument, more and more outcome data are coming for the robotic surgery. I think through the comparison of this data with the existing standards of care, the future will show that robotic surgery will replace the standard laparoscopy in the complex surgical procedures, such like the locally advanced rectal tumor. Thank you for your attention.
Thank you very much, Esther. And we we will have our speakers talk on cons of robotic surgery. And our speaker is Professor Stephen Rachner, someone who need not to be introduced, a famous professor from Cleveland Clinic, Florida. And Dr. Rachner is my mentor as well as a good friend. And I think he's going to give us some different ideas about robots.
Well, thank you very much. Again, it's my last talk at the meeting, and I want to once again thank you for the honor of bringing us back here to speak at your meeting and congratulate you on an outstanding, raving success. I may give you some different ideas. Oddly enough, they're based on the exact same data, and it just depends how one looks at the data, of course. It's a bit like a political debate. Now, I do have a disclosure that's relevant. I have stock options in Intuitive Surgical for consulting that I did for them from 2001 to 2005. So, as I like to say, please keep doing that because it's good for me. So go ahead by all means and do the procedures. Whether I feel they're good for my patients is rather a different story, but it definitely benefits me. A lot of people are helping drive that. Right around the time I was doing my consulting, Newsweek came out with this wonderful photo, and we've seen all kinds of advertisements. My favorite, I couldn't find a copy of it in Naples, Florida, where one of our alumni, Sue Sarah, was in the Naples Daily News with a title that was Naples Surgeon Cracks the Da Vinci Code. I rather like that one, but I'm unable to lay hands on it. You know, we just saw the advantages, but what we didn't see are some of the disadvantages, the lack of haptic sensation and tactile feedback, the docking and undocking, which in Michael Lee's unit is very rapid. Hester's unit is very rapid, but in much of the world is very slow and very cumbersome and adds a lot of time to the operating room. And many people, because of the difficulties with multi-quadrant surgery, end up doing the so-called hybrid approach, with laparoscopic mobilization of the flexure, laparoscopic division of the vessels, then dock the robot for the procedure. So you're not only adding the cost of the robot, but you're now adding all the laparoscopic gear as well as the robotic gear. And these things can be overcome with some of the newer, like the XI robot, but the problem with the business model for us as end users is the business model isn't that you add on to it. It's not that you get a new component for it, it's that you have to replace it. It's like getting a brand new car. So you can't make your 2010 car into a 2015 car. You trade it in, you hope you get some reasonable value and don't get too badly taken advantage of by the dealer, and now you have a 2015. So you can overcome this as long as you're willing to just keep paying more and more and more money. And in the interest of time, I took out the financial slides, but you can find these things on their website. They're very proud of the money they're making with the technology. You can see in 2010 the different procedures, with clearly prostate being the soft spot. And that's rather interesting that the incidence of prostatectomy has significantly increased in the U.S., about 14% a year, despite the fact that the incidence of prostate cancer has decreased. So with decreasing amounts of prostate cancer and increasing alternative therapies for prostate cancer, the amount of prostatectomies has increased, but that's another story, having more to do with ethics and the Mark Twain theory, when the only tool you possess is a hammer, the entire world appears to be a nail. So if you want to do robotic, you do robotic. So here's 2010. 2010 for colons. As we move into 2014, everything shifts up, and colon has shifted up too, due to a lot of marketing and the theory of the Reverend Jones from Guyana and drinking the Kool-Aid. The patients drink it, the surgeons drink it, and the media drink it. But every so often people sober up from the Kool-Aid and look and see that there are indeed a lot of problems that are out there with robots. Some of it due to the lack of haptic feedback, some due to the fact that although in the Pamela Youth Medical Hospital, it's fantastic surgery, I've watched it, I know Hester and Michael are brilliant, technically gifted surgeons doing a high volume. But remember from my other talk this morning, the average general surgeon in the United States operates on 2 rectal cancers per year, 2, and performs 0.6 abdominal apparent resections a year. So keep that in mind as we look at learning curve, and you see why some of these problems happen. Now, we've heard for so many years that the advantages are coming, the advantages are coming, the advantages are coming. look at papers published 10 years after Moises Jacobs' first papers. This is 10 years into it, 2001 to 2006. 188 published reports of laparoscopy versus standard of care, and a whole list and 20,000 patients of significant advantages. Not didn't reach statistical significance, or not quite there, or not, these are potential benefits, or these are theoretical, or this should happen. No, this did happen. So within 10 years of laparoscopy being introduced to our practices, we have repeatedly proven these things throughout the world in study with very statistically robust data within the first 10 years. Now, the first robotic cases were done in about 2004, so we're now 10 years into it too, but we're not seeing the same story just yet. As we started going on, laparoscopy versus standard of care with another almost 200,000 patients, we see all of these benefits too, including decreased cost, for sure, and also, in many studies, preservation of urinary and sexual function versus open surgery. Look at a few specifics. Look at the color trial. We saw it earlier. And, putting aside some of the statistical problems with the study, nonetheless, significant advantages over open surgery, not equivalent, seemingly significant advantages, without any tumor compromise in terms of the completeness of TME, the distal margin or the radial margin. Looking at some of our data with Marilise Boutros, one of our alumni, and Mariana Barrow, we find by laparoscopy we actually get more lymph nodes than we do by open surgery. It's not equivalent, it's better. We're getting more nodes laparoscopically. Does it pan out nationally? Look at this study of an insurance database in the U.S. of about 2,800 colectomies. We are saving about $15,000 per case. That starts to be real money, even in federal U.S. government terms. When you multiply it out by roughly 200,000 colon resections, 250,000 colon resections per year, if they're done laparoscopically instead of open, that can buy a lot of robots with that money. Cost benefit, less complications laparoscopic than open, shorter hospital stay, not equivalence, superiority. Duration, and you can see why. I mean, if you look at it, the cost of care, the adjusted cost, the difference, you start to save a lot of money when you're performing these procedures laparoscopically. Now let's turn to robotic for a moment and see how that compares. Are we seeing these same advantages 10 years, a decade into robotic colorectal? 15 months, no advantage of morbidity, no advantage in terms of lymph node harvest, no advantage in terms of specimen length, no advantage for lymph nodes retrieved, no advantage for surgery time. In this study, no advantage for conversion, but granted it's an early study. So let's go on to some other studies. 5 years later, still no advantages. No advantages in complications. Morbidity was not lower, as it has been proven to be laparoscopically numerous times. Operative time was significantly longer, unlike laparoscopy, where it's actually decreased under open surgery. Are we doing better in oncological terms? Well, it seems we're doing worse in this study that's only 3 years old. Mean number of lymph nodes, fewer robotic than laparoscopic, and complication rate roughly threefold higher. But again, not statistically significant. I can't point to that. But when we start doing this spin and saying which way we'd like to spin things, well, if I were to spin this, I'd get yelled at from my friends from France. But if I was, I would say, well, we don't get as many nodes, but we do get more complications. How about another study, relatively recent study, median operative time, adding about an hour. I don't know about in Taiwan and in other countries, but we don't have an extra hour to spend in the operating room. And operating room time is the most expensive variable we have in all of the episodic hospital care that we offer patients. Operative time longer. Again, this one's even more so, laparoscopic versus robotic. And again, here's what I was referring to. Open, 233 minutes, laparoscopic, 158. Robotic, we go right back to where we started from open surgery. But, with no other advantages. Everything else is the same. No saving on morbidity, no saving on hospital stay, no benefit in terms of margins, nothing, nada. No benefits at all, but a disadvantage of more time and cost. Or another 2011 study showing, again, more operative time, but you get the picture on that. So let's look at another systematic review. We saw one, let's see another one. 8 trials, 344 robotic, 510 laparoscopic. Yes, there was decreased conversion. but everything else was absolutely the same, including hospital stay and morbidity. And if we go to one of the other trials, 15 robotic colonic surgical trials compared to the Cochrane Review, 4 randomized controlled colon trials, robotic surgery versus laparoscopy, costs more, took longer to perform, without any advantage for complications or conversion rates in the study. So again, it depends which study you cite, what you're going to find. There is clear selection bias, huge selection bias. This is the one that was mentioned, 18 studies, 11 case studies, 7 comparative, yes, costs more, yes, longer operative time. And again, look at the wording. I mean, this is something I'd expect Obama to come up with in a debate with the Republicans. You know, the Republicans say the same thing. Potential benefit. No benefit, but there's potential benefit. Hey, you know, can I pay my mortgage with potential income? I don't think so. I don't think the bank will allow that. I need real money, okay? So I don't have a benefit, but I have potential benefit. It's safe and feasible with equivalent complications in experienced hands, but most of the surgeons aren't experienced. They're not all working at Convalescent Youth Netherlands Eastern Hospital. Potential shorter learning curve. Again, come on, potential, give me a break. Increased operative costs, that's real, and increased operative time, that's real. So there's a study that we put in this year for ASCRS. I don't know if it get accepted, depends how many robotic enthusiasts are on the program committee, but nonetheless, we looked at 38 robotic studies, including 24,000 patients, and we're looking where robotics are compared to laparoscopy in colorectal patients to look at something called SPIN. In other words, how honest are these articles on robotics? So what we found was that 82% of the assessed studies has SPIN, just like we saw. You know, don't actually pay attention that it's not statistically significant. Just say that it's better because that's what you want to say. So the most common form of SPIN was concluding, and again, we're obviously have an expert in the audience, or at least one. The most common form is concluding equivalence between technologies based on non-significant differences. 80% of robotic studies. Claiming improved benefits of the robot approach despite non-significance, 47%. And surprise, surprise, 50% of the studies did not disclose whether or not they received funding and did not disclose potential conflict of interest of the authors. We'll see what happens with it. Now, getting to the point of does it make surgery easier, look at the learning curve. Look at this QSIM analysis here. Mastery phase after only 25 cases. Well, guess what, folks? If the average surgeon in the U.S. is doing 2 rectal cancers a year, that's 12 years from now they'll have mastered it. But I don't know that time sensitivity doesn't enter into it. Now we're told it's a multi-phasic learning curve. You need an initial phase of 35 patients, then a second phase, as we heard, more challenging patients, 93, and a concluding phase. And then you retire. Now here's another QSIM analysis, and you can see here, you know, it goes up and down. So this one is getting even further out. You're seeing it flattening out somewhere about 175 cases. I mean, how many surgeons are going to get to do 175 robotic rectal cancers? 130 consecutive cases. What happened with this one for learning curve? Initial phase, competent phase. So you can be competent after something like 75 cases, which most people probably won't see in any reasonable length of time in their practice. But while you're learning, the good news is you can learn. As long as you've got all those patients, you can learn. As long as your hospital administrator is willing to bear the burden of the increased costs to do it robotically, because it costs more for the OR, more for personnel, more for supply, and more for that precious time. Looking at the national inpatient sample, for over 20 procedures, including colectomies, the robot added about 6% per case, translating to $1,600. But you've got to depreciate the $2.5 million a year, so it ends up being you're losing $3,200 per case when you do it in the U.S. Conrad Delaney looks at the Premier database, comparing laparoscopic and robotic for similar cases, and you can see here about an even bigger number. About $5,272 more per robotic case versus laparoscopic case. So, I mean, if you've got infinite resources financially, it's probably a good thing to do. It's not any different in Europe, though. You throw in more disposables for the robotic cases than you do for either open or laparoscopic. You've got the depreciation of the platform itself and more personnel running around trying not to get knocked over by the four moving arms. Disposable materials and more, all of these things here. So again, disadvantages across the board in every study. National Inpatient Database looking by volume, hospital surgeon, just like I showed earlier today for rectal cancer. The majority of robotic cases, this is like a day, as Yogi Berra said, it's a deja vu all over again. This is what we said this morning with rectal cancer. Most cases are done in low volume institutions. They're not done by experts like the Pavlo Universal Eastern Hospital. 71% of cases in low volume hospitals, 84% by low volume surgeons. And guess what? That costs even more. Now you're adding about $6,000 per procedure just to be able to market that you do by robot. But oh, by the way, it's not equivalent. And these p-values, I think even our friends from France would agree, are significant. Much higher complication rates, particularly hemorrhage, longer ileus, and longer length of stay with the robot. Not equivalence, not a non-inferiority trial, but an inferiority result. So while surgeons, and I like the quote, and hospitals continue to selectively explore robots, it should be limited to high volume and interested surgeons and hospitals to offer high quality outcomes to their patients. Yes, the roller trial is underway. We saw that, but where we stand now, if we want to do robotically, we have to add more ports. I do my laparoscopic cases with 3 ports. The incision length cumulatively about the same. I've got to add time to do it robotically. I have to trade off. I lose haptic feedback. Yes, I have articulation. Everything else seems more or less equivalent, except the patient stays in the hospital longer and costs me more. So on this slide, I've put all of the level 1 evidence in support of robotic colorectal surgery. There's nothing on the slide. That's because there's no level 1 evidence supporting it. But there may be evidence to support us living longer doing surgery because there's an ergonometric benefit of sitting on the side of the room operating versus standing over the patient. For the hospital, it's an interesting business dynamic that you actually drive more business to yourself when that business costs you money. So you're losing $3,200 to $5,700 per case, depending on which U.S. study you look at. So you're getting more market share to lose more money. Intuitively, it doesn't make sense, no pun intended. Like I said, please keep doing it because I have stock in the company and I got it at a very good price, so I'll disclose that. But thus far for the patient, I can't think of any rational reason to do it. So thank you very much for the opportunity.
Thank you, Steve. Well, I guess you should stay. We're going to have 2 chairs coming up for you and Hester. And we have time for questions and comments. Let's open the discussion to the floor. Anybody have any burning issues they want to discuss? Any questions? Any comments? Yes, please.
Thanks for both of your excellent talk. For the robotic surgery, I want to ask Dr. Chuang, I see your patient, among your robotic surgery patient, a patient received a Hartmann procedure by the robotic approach. Could you explain what you're thinking to do the Hartmann procedure by robotic?
Thank you for the question. Actually, in Hong Kong, because of the improved quality of life of patients, so in public hospital, actually the hospital are probably included the reimbursement for the robotic surgery. So actually the cost is not a problem in our hospital. So in our hospital, actually, with the operating time, the console is, the robot is available. Actually, every rectal cancer surgery, I will use the robot. So that's why even the patient for Hartmann's operation, that we can still use the robot.
You satisfied? Okay. Any other questions or comments? I have a question for both of you. I'd like to know, well, in the study that's planned, the randomized control trial that's planned, the main endpoint is the conversion rate. do you think about that as a endpoint for a study of this type?
You know, it's interesting because there was a talk given this morning, we didn't get asked questions about it, where they had a conversion rate that was something very low, 6% or something. But the range of the incision size laparoscopically was up to 21.5 centimeters. So I don't know what the definition of conversion is. You know, if you have a 1 centimeter lesion and you have a 10 centimeter incision, to me this is clearly a conversion. On the other hand, if you have a 10 centimeter lesion, you manage to get out through a 6 centimeter incision, it doesn't seem like it should be conversion. I don't know how it's defined in the study. And I also think that it's interesting to think about conversions when so many surgeons, I don't, myself not included, perform hand-assisted surgery, which is a large incision to begin with. So, you know, people have to figure out what is it you're looking at. Are you trying to look at something small that should be single port, or robot with 5 ports, or standard laparoscopy with 3, or if you're going to accept an incision for hand, what difference does it make? Anyway, it all depends on the definition.
Yeah, of course, but it doesn't seem that what the study, the goal, if you're using conversion as an endpoint, you're studying something that's not failure, but something that's considered as a step down from the goal, whether it's robotic or laparoscopic. It has nothing to do with patient comfort, it has nothing to do with survival, recurrence, all of the endpoints that we'd like to see compared in a new technology.
Well, I think I agree with that, but what worries me even more is it's totally nebulous, it's totally subjective. It's not even, you could tell the margin and the number of millimeters. You can tell when somebody, even though it's subjective too, when somebody has a valve movement or flatus, somewhat subjective depending on the heat. You know, you could tell the histopathologic variables, you could tell a recurrence. I mean, these are all objective data, but conversion is so tremendously subjective. I just don't know what it means.
Yes, sir? You have anything to add?
Actually, in my opinion, I think the short-term outcome is to assess the operative approach, and then the long-term outcome for cancer surgery is the oncological outcome, and then the conversion is about the technology, whether there is any improvement in technology, because in my opinion, the conversion is anything apart from the dissection and the vascular control, just like the anastomosis and the retrieval specimen, you need to convert into a larger wound and then it's defined as conversion. Just like the laparoscopic one is converted to open, is defined as anything apart from the dissection and the vascular control, and if it is performed with a wound, that is not defined as conversion. So if we can finish the operation and with lower conversion rate, that means this technology can have an advancement in the improvement in technique and the operation for the patients, I think. So that's why I use the conversion, and not just the long-term oncological outcome is for cancer surgery, and the short-term benefit is already very obvious because laparoscopy is better than open, so robotic will also have a definite benefit.
I think if you're looking for benefit of robotic versus open, that's obvious. Yes, there's clearly a benefit, but the issue is finding a benefit beyond laparoscopy, and that's where it's been impossible to find any level 1 benefit compared to laparoscopy. Compared to open is a different story. But again, you know, there's been people in the U.S. who've done this hand-assisted Howell's group, Peter Marcello and Tom Reed, and they've shown that in terms of pain and hospital stay and complications, that hand-assisted and laparoscopy are the same. So a conversion from robotic is basically a successful hand-assisted. It shouldn't be any real gain to the patient. Moreover, I don't see how you're going to get the oncologic endpoints with only 400 patients, because when we look at the color trial with 1,200 patients, and we look at both the COST-1 colon cancer trial with 869 patients, and the COST-2 rectal cancer trial with about 750 patients, they're sufficiently powered to tell something. I don't know, maybe Francois tell us if we're wrong, but with only 400 patients, if it's sufficiently powered to find a survival difference or a recurrence difference. I'm not sure that
I doubt it as well.
I have a question, Professor, that Michael Lee's TMB laparoscopic trial, looking at the urinary function is about 86% after laparoscopy. And how can you improve your urinary, function with high percentage of preserving the function with laparoscopy? Do you think you get a higher number with robotic?
Actually, I think the robot is actually not it's an evolution from laparoscopic approach. I'm not comparing its robot is much better than laparoscopy, but actually with the robot and then with the more and more upcoming data, because currently there is some limitation because of only one market. You have the robotic system, only the diabetes system. If there is any healthy market competition, resources allocation, and the funding, and then with time, I think there will be more coming data to support the use of the robot. Because actually, with the robot, sometimes for complicated cases, I'm not going to use the robot for all the cases. Because for those obese patients with narrow pelvis, and patients with a very distal rectal tumor, like either the sphincter dissection or bilateral pelvic lymph dissection in those patients after neoadjuvant irradiation, and then with the robot, and then it can really facilitate the operation and improve outcome of our patient. So, of course, the functional outcome is one of the points that we are looking for, but not just of the improvement compared with our previous data, because the use of robot is for the general, just like what Professor Lester said, it's not just for the experienced surgeon, because there are also data showing that actually with the robot, people who can learn by doing minimal invasive surgery, the learning curve is shorter than from the previous open, which was laparoscopic. Because of the limitation by laparoscopic, there is 2 dimensions, and then with the endovis, because the robot is not just the 3D visualization, it's also combined with the stable platform and also the endovis. There's a combination of the advantage, and we should overall.
That's why we're talking about the same surgeons here.
But I think one of the other things, we discussed it quite a lot this morning, when you're talking about the obese male and neoadjuvant and distal tumor, we had a lot of presentations on transnasal TME. And in my view, that's something that is a far more cost-effective way to get better distal circumferential resection margins under direct visualization with a lot less expenditure. You know, maybe your hospital, you can do what you like with the robot, but in many places, people don't even have a robot. When you look at the marketing map from Intuitive, they're still largely focused in the US, and then following that Western Europe, and then you start getting it from some other places. But doing a transanal TME, I think, gives you clearly the same advantages in that same high-risk group of patients. So again, I think that may have been an argument until transanal TME came along, and now we have to make a choice which way to go.
That's for sure.
One last question for both speakers. What do you see the future of the robot? Do we